have different effects.
This meeting is being recorded.
But the myocardium can be affected. There can be fibrosis, inflammation, conduction abnormalities. The vasculature can be affected with vasculitis, thrombosis, and vasospasm. And essentially the list just goes, on, and we'd be here all week if we were talking about all of these. But I'm going to focus on the imaging, the role of cardiac imaging in evaluation of cardiotoxicity. So really multimodality cardiac imaging, it's just central to this practice for us. So of course, echocardiography is really kind of one of the mainstays of imaging for our patients. But we'll talk a bit today about the expanding role of cardiac MRI in cardio oncology. And there's also a role for cardiac CT and also a role for nuclear cardiology as well. So actually the landmark studies, as many of you may know, in cardio oncology, using serial radionuclide assessment of doxorubicin toxicity in breast cancer patients was actually used with nuclear MUGA or ERNA scanning actually at Yale back in the late 70s and early to mid 80s, where MUGA scanning was used to assess patients receiving anthracycline. And what they did was they established an algorithm for surveillance. And what you can see here in the Sentinel publication in the dotted line is that those patients who were discordant with those surveillance guidelines actually had much worse heart failure free survival compared to those in the solid line who were compliant. So this really kind of set the foundation for us in cardio oncology in regards to imaging and serially following patients. So over the years, there's been many different guidelines and documents out there. I put up this one that we're most familiar with, which is mostly American Society of Echocardiography and echo based, mostly kind of EF focused, although starting to introduce the concept of strain, which we'll touch on. And really with recommendations of primarily, echocardiography with, you'll see highlighted here, a mention of consideration of CMR, but not that large of a role. So, as our patients get many different modalities, depending upon the institution or the local resources, it's really important to understand the correlation amongst the different modalities. Specifically when we're talking about ejection fraction. So, using cardiac MR as the gold standard, this is a nice, there's multiple publications that have sort of replicated this, but I like this one because it's in breast cancer patients who received trastuzumab as well as doxorubicin therapy. And using MRI as the gold standard, you can see on the left that there's not great correlation with 2D echocardiography. But in the middle graph, you can see here actually very nice correlation with 3D echo. And on the right, you can actually see nice correlation with nuclear MUGA scanning as well. We're not going to go through this, but this is just to show you how, we adapted the national and international guidelines to our institution-based imaging algorithm, kind of leveraging the expertise and the resources that we have available at our institution. Highlighted for you in pink here, many areas where we've incorporated cardiac MRI, circumstances, of course, for workup of a cardiomyopathy, but also when echo is non-diagnostic or for borderline LV function. We also have a liberal use of stress cardiac MR in this patient population, and then utilize a fair amount of PET stress as well as coronary CTA. We actually kind of took a look at this when we first introduced cardiac MRI into our algorithm. You can see here in the green bars on the left, MRI introduction at the beginning. And of course, over the subsequent years, the percent use in our patients grew over time. What's interesting that you can see on the right here is that our course echocardiography remained the main modality that we use in our patients, but you can see that the use did slightly decrease over time, which was statistically significant. And, what we hope this is reflecting is choosing the right test, for the right patient at the right time, rather than just over imaging of patients with multiple modalities. I'll highlight here a table from the recent publication from the ACC, Cardio Oncology, and Imaging Councils. And really what this is meant to be is a very kind of simple, clean definition for the imager. There's many different guidelines out there that incorporate clinical presentation, and those are very important when seeing patients. But for those who are just reading the imaging, this is sort of a nice, clean definition of definite versus possible cardiotoxicity. And what I've highlighted for you here, importantly, is that when 3D echocardiography cannot be obtained, one should consider cardiac MRI as second line. So you're all pretty familiar with strain imaging, which can assess the longitudinal, radial, and circumferential strain, assessing the endocardial, midwall, and epicardial fibers, respectively. What's really important that we want to do with strain in cardio oncology is, yes, we want detection of early cardiotoxicity, but also we want this to have prognostic value. And ideally, we really want it to guide therapy and management in patients. And so you're all familiar with echo strain, which, as you can see here, can be looked at on a segmental basis, but usually in cardio oncology, we will use a global value, as that's been most reproducible amongst the literature, with a normal cutoff of -19 and reductions of greater than 15%, being consistent with cancer therapeutic related cardiac dysfunction. But what's important to know is that you can do strain by other modalities, and specifically with cardiac MRI. So what you see here in the upper right is tissue or feature tracking MRI. It's a similar concept to speckle tracking echo, but with higher resolution images and more points for tracking. And we also have multiple dedicated sequences for strain that we can use in cardiac MR. I've just highlighted a couple for you here. You see on the upper left, fast strain encoded imaging, which takes advantage of the differences between low tuning static tissue and high tuning contracting tissue, as well as tagging sequences as seen in the bottom center. These techniques, they may be more robust, but it's important to keep in mind that they do require a dedicated sequence and some more additional complex post-processing. This fast sank strain by CMR has been applied to multiple studies now, this one specifically in a cancer population. And what you can see is what they're looking at here is % of normal myocardium as defined by segmental strain. And what you're seeing in these sort of the blue lines here, the blue dots, is these are patients, who didn't recover. And so as the amount of normal myocardium goes down, the likelihood of functional recovery declines. So detection of kind of early cardiotoxicity and some prognostic value. This is the same type of sequence by MR strain that was applied to a general heart failure population. And interestingly, what they showed here was, again, looking at % normal myocardium, that was an independent predictor of heart failure stages and had a much closer association with that than left ventricular ejection fraction. But what I like that they've shown here, and what you see is this blue window, is that you start to see these decreases in strain before you see drops in EF. And that's this window here. And that's that window that we want to grab, where you've got potential to get cardioprotective, early diagnosis and cardioprotective therapies on board. This same publication looked at, if you see in blue here, this is the patients with the most abnormal strain. And you can see that had significant prognostic value as far as prognosis for event-free survival. But what we really want, as I mentioned earlier, is we really want this to guide our therapy and our management. So this is a recent study that's been done in the field using echo strain. It's randomized, multi-center controlled trial looking at, called the SECORE trial, looking at an EF-guided arm versus a strain-guided arm. And what you can see that I've highlighted here in pink is the ejection fractions between the two arms at 1 year, at least, follow-up were not statistically significantly different. But in secondary analysis, in those who developed cancer therapeutic-related cardiac dysfunction and received cardioprotective therapy, the reduction in the EF arm was much greater, around 9%, versus the strain-guided arm around 3%. So I think this does hold promise for us in management of patients and changing outcomes. And just as a side note, you can do strain by cardiac CT. This has not been extensively looked at in the literature as far as cardio oncology, but this is a study here in TAVR population showing pretty nice correlation between global longitudinal strain by CT and by echocardiography. So one other way that we can look at more subclinical left ventricular dysfunction is through tissue characterization. And one way we can do this with MRI is with T1 mapping. And you see these color maps here that look at the signal intensity of the myocardium on a pixel by pixel basis. And what you can see here with the correlative LGE images on the left is that they nicely correlate with late gadolinium enhancement. In the cardio oncology population, what you're seeing here in the pink box on the left is that as the amount of anthracycline dose received goes up, so does the extracellular volume fraction as calculated by T1 maps. And on the right, you can see that this correlates to decrease in peak VO2 and exercise capacity in these patients in the long term. Here is an example of AL amyloid patient, and this is one example of actually using T1 mapping to monitor disease extent. So what you're seeing here are non-contrast T1 maps. In these bar graphs, you see that the values go down or improve as this timeline here on the right, the patient is treated for their underlying disease. And that actually correlated with their BNP, their kappa lambda light chain ratios, their LV mass, and overall clinical improvement in the patient. So potential for monitoring of patients with this technique as well. But it's obviously really important to show that there's value in the imaging that we're doing. I like this study, which is a retrospective study that looked at cancer patients receiving cardiac MRI. And what they saw here was that based on the MRI, there was a change in the clinical diagnosis in just over 50% of patients and a change in management in just under 40%. And these were things like preventing or indicating biopsies or invasive angiograms or potentially ICD implantation. This is a figure from the recent publication I mentioned earlier. I won't go through it all, but just for your reference, which sort of really nicely highlights the different types of disease states that patients can present with and different toxicities and multimodality approaches to evaluation, such as myocarditis using MRI, question of atherosclerotic disease using non-invasive coronary CTA, as well as FFR assessment, et cetera. So I'm going to focus a little bit more now about immunotherapy and specifically checkpoint inhibitors, just because this is such a growing area of the field. And as many of you know, this can present different ways. You sort of have the classical myocarditis with T-cell infiltrative myocarditis, heart block, VT, but we're learning more now about acute plaque rupture as well as Takotsubo presentation. So there's some echo abnormalities that can be seen on strain as shown here, abnormalities in strain compared to controls and even in those that have a preserved EF. And it's important to understand that about 50% of patients with myocarditis in this disease state do have a normal EF. So although we're seeing abnormalities in strain, we're not really able to make the diagnosis of myocarditis with echocardiography. But we can with MRI historically, which has been the gold standard for myocarditis evaluation. But there have been some limitations reported in the literature. You can see here, this is a retrospective study of ICI myocarditis. And what you're seeing in blue here are patients with late gadolinium enhancement and showing in this patient population that it was not predictive of major adverse cardiovascular events, which is sort of surprising for us because usually in myocarditis it is. So I think we still have a bit to learn about this sort of variable disease presentation. A sub-analysis looked at those more quantitative mapping techniques and You'll see on the left here in the red, worse survival in those with elevated T1 values. On the right, red, elevated T2 values did not have prognostic values. So we're still kind of learning about the quantitative assessment here. We looked in our study at quantitative late gadolinium enhancement, as you see in panel C, and for those patients without T2 mapping, we looked at more quantitative assessment of myocardial muscle, to skeletal muscle ratios. And what we saw, again, was that about 50% of patients had a normal EF, but with these more quantitative assessments, 85% met at least one criteria for myocarditis. We then applied feature tracking strain, as I had discussed earlier, and that also by cardiac MR is low in these patients. And similarly to echo, in preserved EF, the average GLS remains low by CMR feature tracking strain. We applied in a small cohort the dedicated fast strain encoded imaging. And as you can see in red here, significantly increased number of dysfunctional segments in those with myocarditis compared to controls. So some promise in that technique as well. But it's important to understand it's not all about myocarditis. So this is a patient who was thought to have myocarditis in the top row here. But what you can see on delayed enhancement is a transmural MI with central microvascular obstruction. This patient in the bottom panel had a isolated pericarditis without myocarditis. So there's some variability. And there is some study looking at increased composite cardiovascular outcomes in those post-immunotherapy treatment, as you'll see here in these red bars for composite, as well as MI, ischemic stroke, and coronary revascularization. So we're still learning about the role and plaque progression and potentially plaque rupture, and just show you the utility of coronary CTA in a case here that had a low-level myocarditis and chest pain, but on the workup with coronary CTA, you can see this hazy non-calcified stenotic lesion in the left anterior descending artery. In the middle, you see the FFR-CT, which shows hemodynamic significance at 0.5. And on the right, you can see that the invasive angiogram correlatively shows significant stenosis for which the patient received a stent. And, it's not all about the left ventricle. We're starting to look at the left atrium, and this is just some early prelim data about the left atrium and some of our myocarditis cases where a fair amount have delayed enhancement, and they don't even all have LV delayed enhancement. So what's going on in the left atrium? Is it all secondary to the left ventricle, or is there some intrinsic inflammation or fibrosis, happening there? On the left, you'll see here the central illustration from the recent council publication, which I'll just refer you to as a resource that I like, nicely kind of lays out the different strengths and limitations of the modalities, both, all the way from pre-cancer treatment risk up to cancer survivorship. And I'll also point out on the right, this is the central illustration from a recent Society of Cardiovascular CT consensus document for the use of CT in Cardio Oncology, which is a really great resource as well. Future directions, I think cardiac imaging is a significant component, but as you can see here, it's probably going to be quite multidisciplinary with multiple, genomics, metabolomics, et cetera, contributing to precision medicine, in the field. And this is just kind of one biomarker. So summing up, our goals for multimodality imaging and cardio oncology are really to deliver high value and equitable cardiovascular care to our patients. We want to drive cardiac imaging innovation and discovery. Of course, we want to deliver clinical excellence in a multimodality cardiovascular imaging way and with a multidisciplinary collaboration spirit. And in conclusion, I hope I've showed you that advanced imaging is an integral component to cardio oncology. MRI specifically holds a value for myocarditis. The technology and imaging in general is moving towards more quantitative and sensitive techniques, and there's just such great opportunity for growth in the field. So I would like to acknowledge my colleagues in MRI, CT, the MR Research Center, Translational Imaging Center, as well as our Cardio Oncology program as well. Thanks so much, and look forward to discussion when we have time for that.
Thank you very much for the great presentation. There's one question for you, Lauren. What's the cost concern for multimodal imaging in the oncology patients, cardio oncology patients?
Did you say what's the cost? Is that
cost? Yeah, the cost issue.
Yeah, I mean that's a great question. I think obviously we want to use our imaging wisely. We need more data in this space, showing us what's cost effective. I mean, I think MRI is a great example. Some people assume, well, it's just too expensive. Well, not always. I mean, and if you're going to get another test first and then that after, maybe you should have gotten that test first. For example, if a question is EF, you don't need contrast. You can do an exam in 15, 20 minutes less if you just need function. So I think it's more, the point is a great one. I think we need more data in this space. We don't have it. But I think it's more about, picking the right tests for the right patient at the right time rather than over imaging. Because yes, the cost, can become significant, and especially in populations that are under-resourced as well.
Right. And also just 1 30-second question, a lot of interest in the right ventricular imaging in assessing cardiotoxicity.
Yes, great point. Again, there is some, initial data showing that the right ventricle may be affected. That's coming out from echo, and it has, as in other fields of cardiology, been the neglected ventricle a bit, but definitely there is the possibility of some toxicity there, direct cardiotoxicity, but also some of these toxicities, some of these agents can cause pulmonary toxicity. So some of that is secondary in a fair amount of these as well. So a great point. Yeah.
Thank you very much.
Thank you.
Our next speaker is Dr. Erica Origino, who had a UPenn medical training and the Yale cardiology training. He's the director of Cardio Oncology at Hartford Healthcare System. Thank you very much, Erica, for the presentation. We're looking forward to hearing you.
Great, thank you so much. And Lauren, what a fantastic talk. Thank you for having me. And thanks to the Connecticut Chapter of the ACC. This talk, I think actually dovetails nicely to the multimodality imaging talk that we just heard. A lot of times when we're looking at cardio oncology, we think of cardiotoxicity. But as cardio oncologists, we want to make sure that we can weigh the risk-benefit ratio. So we do want to make sure we have some understanding of the benefit of the treatments they're receiving, so it can inform us of what we might be giving up if we have to stop or alter the treatment regimen. And I think this case is a nice anti-HER2 case that demonstrates that. So I have no disclosures. So case is a 74-year-old female with hypertension, diabetes, Parkinson's, diagnosed with right breast invasive ductal carcinoma, stage 2, ER positive, PR positive. It was HER2 equivocal by staining, but the FISH was positive. She underwent lumpectomy, and the plan was adjuvant taxotere, carboplatin, trastuzumab, and pertuzumab, followed by radiation therapy. The baseline echo was normal, EF68. Strain was technically difficult and not reported. It was otherwise normal. Medications included lisinopril. And then she had a 3-month follow-up echo. The EF was 50%. She was having lots of PACs, which can sometimes make it more difficult. I'm going to not show that echo for the sake of time, but we have other imaging that we'll be able to see. It's now the question is now what? So, I think the first question we have to ask ourselves is, does this meet the definition of cancer therapeutics-related cardiac toxicity? And the European guidelines that just came out in that expansive document that we all should spend some time with does a nice job outlining and really distinguishing between symptomatic and asymptomatic CTRCD. And our patient is really right in the cusp of moderate CTRCD, right? So they're having an EF greater than 10% drop. It's 50%, so right at the cutoff of 40 to 49. Versus mild, which is EF 50 or more, but with a new abnormal strain or new biomarkers. So when that echo had happened, that's when she got sent to the Cardio Oncology clinic. So we didn't have any more of that data. And in this document, it talks about, and this is probably the first key teaching point, is what to do up front. So it used to be, if there's a drop, there's sort of a reflexive hold on some of these therapies. And we know that's probably overdone, particularly in anti-HER2 therapy. So in this document, so for mild CTRCD, it's a class of indication to continue it with closer monitoring. There's a recommendation to start ACE inhibitors and beta blockers, and then to make sure, if possible, to get strained and to leverage biomarkers with high sensitivity troponin on a pro-BNP. Even if it's moderate, so EF in the 40% range, 40 to 49, if they're asymptomatic, there is evidence to continue anti-HER2 therapy with closer monitoring. And what is this data? So again, for the sake of time, we don't have enough to go through all of them, but there's two small trials, the Safe Heart trial and the Scholar trial, and it looks at heart event rates, right? Because we all know that the number, the EF is just a number. We really care more about hard outcomes. There's a small study, 30 patients, and 27 had no clinical events, 3 had cardiac events. The 2 cardiac events were just mild heart failure, and the one other was asymptomatic EF at a predefined endpoint of less than 35%. So generally safe to push through and with appropriate monitoring and therapy. So with our patient, came to Cardio Oncology clinic, I got the troponin, so high sensitive troponin, which was normal at 7. Pro-BNP is 126. In that document, 125 is considered the upper limit of normal. Lisinopril was continued. Metoprolol was started, both for the PACs and for potential cardioprotection and GDMT. And anti-HER2 therapy was continued, but we did do an earlier imaging per guidelines for a 1-month follow-up echo. Is this the follow-up echo? So just from parasternal short and the apical 4, just from sort of a visual assessment, at least to my eye, the short looks more like a 35% range. The apical 4 may look a touch snappier, maybe closer to 40, but as we know, we want to be more quantitative. So the Simpsons 2D came out to be 39%. The 3D came out to be 40%. You can get a strain-derived EF, but the strain was technically difficult, so didn't get an accurate EF. So, the question is now what? You're right on the cusp between moderate or severe. If your EF is in the 30% range, now you're in the severe asymptomatic CTRCD, and you're more obligated to hold anti-HER2 therapy. But some views it looked a little better, so the EF is sort of right on that cusp. So we got repeat biomarkers. Troponin was 10, still normal. Pro-BNP did go up to 445. Clinically, she was asymptomatic, although she's on chemo, maybe a little bit, hey, I'm a little bit fatigued, etc. Her exam was completely benign. And so we took a page out of our keynote speaker's address and got a cardiac MRI because we want to make sure before we say you need to hold therapy, we want to be sure that quantitatively we are in the range where it's appropriate. So this is the apical and multiple slices of short axis, and the EF by cardiac MRI came out to be 38%. So it did correlate very well with our quantitative echo and does qualify for severe asymptomatic CTRCD. So at that point, the anti-HER2 therapy was held and GDMT was maximized. So lisinopril was changed to Entresto, metoprolol to carvedilol, spironolactone was added, and Jardiance was added. And I think we just had to take a step back for a second and to say, what's the implication of what we just did? So this is a seminal New England Journal trial looking at what's the effectiveness of anti-HER2 therapy versus placebo that got Herceptin or trastuzumab approved. So the 2-year survival or the overall survival really had a hazard ratio of about 50% for the patients that received the anti-HER2 therapy, or an absolute risk reduction of 8%. So that's what we're asking our cancer patients to give up, that 8% absolute risk reduction by withholding their therapy. Or are we? So, the trials, that seminal trial was done for a year worth of anti-HER2 therapy. That doesn't necessarily mean that that's what is the minimum amount required to achieve the oncologic benefit. So the Persephone trial looked at 12 months versus 6 months duration of trastuzumab, followed them out for 5 years, and you can see the event rates the curves are superimposable. There's more data for 1 year versus shorter duration with a meta-analysis of close to 11,000 patients that followed patients for 10 years. And again, you see that the disease-free survival on panel A and the overall survival on panel B are very, very close. So even if we say you need to stop sooner, certainly 6 months and potentially 4 months might be enough of anti-HER2 therapy to have durable oncologic benefit up to 10 years. So in this patient, I think her therapy was held and she got the follow-up 1-month echo up 45%. So the question is, why is it incomplete? Why did it not increase back to normal? For one, I think we have to remember it doesn't always increase back to normal, right? So there's this teaching that anti-HER2 therapy often EF decline often recovers once you stop the therapy. This is data from the Cleopatra trial, which was looking at dual anti-HER2 therapy versus single agent. But the reason why I show it is that in that trial, they looked at people who had EF decline to less than 50%. Once their treatment was held, what percentage improved back to a normal baseline above 50%? And in both arms, there's 72% and 86% of people who recovered. So there's a good, 15 to 30% of patients, at least in the short term, 45 days out, that won't recover even if their medicine is withheld. And so the other thing we have to ask ourselves is this concept that we talk about a lot in cardio oncology as cardiovascular reserve. So an older woman, 72, diabetes, risk factors, does she have some other underlying substrate that's making her heart more susceptible to the negative effects of her cancer therapy? For her, and most common would be coronary disease. So while the oncology team was determining what to do as far as restarting or not, we want to make sure that she not have any significant coronary disease that might be a reason why her heart is more susceptible to anti-HER2 CTRCD. So the perfusion was normal, but I show this for the gated SPECT, which the gated SPECT now visually is normal, and the EF was 69%. So now we have a patient whose EF is completely recovered, who did have CTRCD to anti-HER2 therapy. So the question is, do we re-challenge? So do we re-challenge them? And that I always think is a tough question. So are you doomed to have a repeat drop in EF if you've had it once before? So there's some small studies on this, and one I highlight is from MD Anderson, single center, 218 patients with HER2 positive metastatic breast cancer. And again, we know that for metastatic disease, we may push the envelope a bit more with allowing some sort of permissive cardiotoxicity, which is a new term that is commonly used now in cardio oncology. So 26 patients with cardiotoxicity and EF recovered, had recovery, and they were re-challenged. 16 had no additional cardiotoxicity, 10 had recurrent, and of those, when you stopped it again, 5 recovered and 5 still had mild asymptomatic cardiotoxicity. So small trial, but it does give the idea that you're not doomed to have, if you've had a drop once, you are going to have it again. It may not happen. And certainly if you start adding GDMT to these patients, it may even go down further. And sort of what we talked about before, are there ways to risk stratify? Who are the people, whether it's biomarkers or imaging, who are the people that are going to be more likely to have this repeat hit when they're re-challenged? So back to our case, we got to remember initially, so this patient, I didn't want to get into the weeds of it. The patient, their initial biopsy was done outside. There's a question about the heterogeneity of the HER2 positivity to it. So ultimately, she had already received close to 6 months of anti-HER2 therapy. It was unclear, how much HER2 was overexpressed in her tumor. And so the ultimate decision by really the teams, even though she was clear to resume anti-HER2 therapy, was to remain off of it. And so in summary, key teaching points: asymptomatic cardiomyopathy, EF of 40% or more, you can continue anti-HER2 therapy. And that's really game-changing, and it's really paradigm shift, especially for more seasoned oncologists who I think reflexively stop it, or cardiologists who aren't abreast to cardio oncology info reflexively. And one of the biggest roles I think that we have in cardio oncology is to avoid unnecessary interruptions in their therapy. Biomarkers are important to help risk stratification. We want to leverage multimodality imaging, especially for function quantification. And we need to have some understanding of the benefits of the cancer therapy to weigh against the risk. Nobody's expecting us to be oncologists, but we do need to know the implications of asking patients to stop certain therapies. Shorter duration of anti-HER2 therapy may be as effective as 1 year, and then an anti-HER2 re-challenge can be safely done with close monitoring. And with that, I thank you.
Excellent presentation, Eric. Dr. Olia has a question for you. How you handle her go with the guideline therapy moving forward? Also, I'm also personally interested in using an SGLT2 inhibitor in this patient. with a class 1 indication now. It's going to be a fascinating evolution.
Yeah, I also think, Entresto, I think it'll be interesting to see how Entresto works in these patients versus ARBs and ACE inhibitors. Jardiance was added to her more because of the elevated pro-BNP, and she did have class medication in that setting. And I'm sorry, Dr. Oya, what was your question?
Now that she's had EF recovery, would you continue her on the guideline-directed medical therapy or de-escalate it? That's the practical part. Patients, of course, want to come off medications if they can. I guess we don't necessarily have the answer in this scenario.
That's a great question. So obviously in the throes of getting her therapy, of course we would keep her on it while she's getting the insulin. The teaching has typically been in any cardiomyopathy to kind of continue them after they recover. There was an article most recently that actually looked at this in the Cardio Oncology world and did say trying to de-escalate thereafter could be attempted and might be safe to de-escalate. So that was something I literally just read over the last few weeks to try to de-escalate, typically starting with a beta blocker and then continuing the ACE, the ARB. So, and you're right, especially, young breast cancer, young women, breast cancers, that have this, decline just in the setting, in particular with non-anthracycline based regimens. Definitely, I think it's appropriate to de-escalate. And it comes down to clinical judgment. If you have an anthracycline based one that got a dilated boggy heart up front and you really had a big save with their turnaround, you have to make it individualized. But I don't think you have to continue it forever. And I think de-escalation is appropriate, but as you point out, very tricky.
Dr. Mom has a question for you.
You're on mute, Brian.
Sorry, great review, Eric. That was an awesome case. And the question I have is, like, in patients that have an LV decline that requires interruption of their therapy, and then they have some recovery, even partial recovery, and then they're re-challenged, is the monitoring different, more frequent for surveillance? Is there sort of more regular assessment of biomarkers? What's different between, the usual monitoring?
Yeah, I mean, usually when they're in the maintenance phase, after they're done with the loading phase, like anti-HER2 therapy. So the short answer is yes, you monitor them more closely. For anti-HER2 therapy, when they're in the maintenance phase, they're usually getting the infusions every 3 weeks. Echoes are typically every 3 months. So a lot of times you can time it where you can kind of do it. You have 3 weeks, you get a therapy, get 3 weeks through, maybe do one more either before or after that second dose. So ballpark 4 to 6 weeks is sort of a common time frame to repeat the echo. Once you have at least two stable EFs after therapy has been resumed, you can then space it out again to the routine monitoring. And then, we're trying to figure out what the best way to do with biomarkers are. I have found that biomarkers, particularly pro-BNP, I think is very helpful for baseline. And then when patients start having, I'm a little short of breath, I'm a little fatigued, you don't know what's doing it. The European data, the Cardinale group and the European data really talks about high sensitivity troponin, and that in Europe they use it a lot. The assays have just become so much more available now that using it is tricky. If you actually look at the articles of how they do it, they draw a lot of troponins to be able to get that benefit to figure out who to risk stratify. So practically speaking, it's tricky, but a lot of times we'll get it before infusions. And I think troponins are a little more helpful for anthracycline-based regimens personally. Any other? All right, great. Thank you.
Our next presenter is Dr. Sarah Hall. She's going to talk about shared decision-making in cardio oncology. And you'll find out soon why. She's an undergraduate from Harvard. She went to UPenn for medical school, and she joined Yale New Haven for fellowship and then faculty since 2014. Dr. Hall is the director at Yale School of Medicine, where she also teaches medical ethics to students and cardiology fellows. She has served as an ethics consultant to the Advanced Heart Failure and Cardiac Transplant team at Yale New Haven Hospital. She also was appointed Associate Director of the Program for Biomedical Ethics in 2019. She served in ethical committee at Yale New Haven Health. Her most recent work is focused on ethical issues involved with ventricular assist devices as destination therapy, ethical consideration in care of patients with recurrent injection drugs, use related to endocarditis, shared decision-making in cardio oncology, nutrition ethics, and ethical issues raised during COVID pandemic. Dr. Hall, please go ahead. Welcome.
Now I'm unmuted, I think. Thank you so much to the organizers for inviting me to give this talk. And thank you to Eric and Lauren for great talks. And sort of, along the idea of nicely dovetailing, I think some of the questions that came up with that last case really nicely dovetail with the topic of shared decision-making in cardio oncology. Because we often can be tempted to sort of take responsibility for that decision ourselves. For example, do we de-escalate therapy in a patient who's had cardiotoxicity and then recovers? And the data would suggest that your risk of recurrent drop in EF in general with patients who have a low EF is higher than someone who never had a low EF. But again, that might depend on the patient priorities. How important is it? For some patients, that priority may be avoiding recurrent cardiomyopathy at all costs, and other patients may prioritize minimizing their medication burden. So it's a kind of a really nice segue again into this talk, where I'm going to try to present maybe a slightly more formalized framework for how we can think about these discussions and how we can approach our patients with this decision making and really be their advisors and also their partners. So with that, I'm going to move on. So I have no relevant conflicts of interest to disclose. And let me just fix my screen here. Okay. So just for an overview of what I'm going to discuss today, I will briefly touch on sort of the ethical rationale for why shared decision-making is an important conception, and also sort of, again, what a helpful framework is for thinking about the kinds of choices that are most salient in the shared decision-making space. And we suggest that the shared decision-making may be particularly useful in situations when interventions offer unclear benefit and patients feel overwhelmed by cancer treatment, when there's no clear, quote, good option and patients are forced to choose between the lesser of two evils, and when cardiac interventions offer clear benefit in themselves, but less so in the context of underlying malignancy. So with the rising cultural emphasis on individualism, the pendulum of modern medical ethics has swung from sort of a focus on beneficent paternalism to favor autonomy as really the paramount principle in the delivery of healthcare today. So as you all know, autonomy, the way we operationalize it, really hinges on the concept of informed consent, which relies upon the physician presenting risks, benefits, and alternatives of diagnostic or therapeutic options so patients can decide how they want to proceed. However, as we also all know, if this isn't done well, a strictly autonomous or autonomy-focused approach can leave patients with really complex decisions that often they themselves are unprepared to make on their own. If we present too many choices with too little guidance under the guise of maximizing autonomy, I actually argue that that does a disservice to patients. Psychologists have described how seemingly unlimited choice architecture is actually very demotivating and dissatisfying for consumers. And more importantly, patients aren't just consumers of medical services. They elicit our advice based on our expertise. On the other hand, as clinicians, we have to be mindful of our own potential bias when we are counseling patients. So in short, when physicians assume too much responsibility for decision-making, kind of like the old school paternalistic model, we risk ignoring patient priorities, which certainly we've seen. But when we go too far in the other direction and we assume too little responsibility, we actually risk enabling patients to make insufficiently informed decisions that may actually run counter to their goals or their values. So it's really important for us to interrogate those. So again, as we all know, patients often find cancer treatment very overwhelming, as it typically requires frequent encounters and often imposes significant discomfort. We also know that some patients really prioritize maximizing all potential benefits of any therapies that we can offer, and other patients really prefer to minimize all but absolutely necessary interventions and encounters with the healthcare system. For example, cardio-oncology specialists often receive referrals for vague symptoms such as intermittent palpitations, which sometimes are an indication of significant cardiac pathology, but other times may just be an indication of stress and anxiety. And that isn't always immediately able to be parsed out. So while an event monitor may be indicated for definitive evaluation of symptoms like this, patients who are otherwise asymptomatic from a cardiac standpoint with normal EKG and echo and exam are likely at fairly low risk for significant cardiac pathology. So in cases like that, whether to proceed with rhythm monitoring that many patients might find quite cumbersome or irritating, but other patients might find very comforting or reassuring, then has to be a shared decision that should be discussed on an individual basis. Similarly, again, going back to the example that we discussed before, patients may be very reluctant to augment an already extensive medical regimen because this is something that they commonly cite as being very burdensome when they're undergoing cancer therapy. So there are some cases where they should be really strongly encouraged to initiate additional therapy. So in the example of cardiotoxicity, or even in the example of poorly controlled hypertension, either just before starting anthracycline chemotherapy, because we know that significantly increases the risk of cardiotoxicity, or antihypertensive therapy to counteract VEGF inhibitor-associated hypertension to prevent cardiotoxicity from TKIs. The indication might be less strong in other cases. Let's say someone has borderline elevated lipids, and the guideline, they're sort of right on the edge of the guidelines as to whether or not they should consider statin therapy. In those cases, it may make sense to hold off, and then after completion of cancer therapy, pursue more aggressive lifestyle interventions, which are often challenging in the throes of chemotherapy, again, when there are a lot of other side effects. So again, the magnitude of benefit versus the trade-offs of intensifying preventive therapies, such as care burden and medication side effects, needs to be made clear when you're counseling patients and helping them to decide on the best approaches. Also sort of harkening back to the previous talk, in recent years, the high frequency with which screening echo is recommended with potentially cardiotoxic chemo has been called into question. It causes inconvenience, it causes financial burden, and it may confer more substantive risks in certain contexts because we know, for example, the data show that interruption of trastuzumab for the treatment of breast cancer has been associated with decreased recurrence-free survival. And concern for cardiotoxicity can be a common reason for this interruption. There's some debate in the cardio-onc community about whether the guidelines should relax serial imaging recommendations for lower risk patients, such as those without traditional CV risk factors and without prior anthracycline exposure. And so, again, this is an example where I think shared decisions can be helpful. We also sometimes see this in the case of patients with metastatic HER2-positive breast cancer who may be on trastuzumab for many years, and after a year or two find getting an echo every 3 months to be quite burdensome, and getting 2 echoes a year rather than 4 seems reasonable in these patients if they have a normal echo at baseline. And so often what my practice has been with these patients is to relax to Q6 months if they've demonstrated stability for, let's say, 18 months, with the understanding that technically the recommendation is Q3 months, and they understand that, and B, that if they were to have any new symptoms, any new exam findings, EKG findings, or any change in serial echo, we typically will revert back to Q3 month echoes until we've clarified the trend, augmented protective therapy, et cetera. So again, there's not kind of this one size fits all model, and really pending further outcomes data to help refine risk assessment and develop more tailored guidelines for screening algorithms, there's a particularly salient role for shared decision-making in this domain. Oh, sorry, I should have clicked that there. Okay, so sort of in the next context, cardio-oncology patients often can find themselves in this stuck between a rock and a hard place situation when the risks of withholding therapy are comparable to the risks of initiating therapy. Decisions about anticoagulation are often especially fraught, which our team encountered in a patient referred to us with metastatic lung cancer who had an MRI demonstrating left atrial invasion of the primary tumor with overlying thrombus, for which he was initially started on enoxaparin. And of course, the initial strategy of anticoagulation for left atrial thrombus seemed very straightforward. This was complicated by a real risk of hemopericardium should the mass infiltration propagate. And we discussed this in our Cardio Oncology conference, and most of our clinical team members felt that we would pretty clearly rather experience a fatal bleeding event than suffer a debilitating stroke. But again, this is an example where we have to be mindful of our clinician bias. And we need to present these choices to patients really as objectively and as sensitively as possible so they can choose for themselves, because they may have different personal and cultural values. In particular, physicians often place a very high value on protecting cognitive function, where patients may prioritize avoidance of suffering. So we had a comprehensive discussion with this patient, and he did elect to continue anticoagulation, but we changed enoxaparin to apixaban just for the sake of convenience, so that we wouldn't have to monitor INR and minimize the discomfort associated with that, despite the lack of evidence supporting apixaban for this specific indication. We also had another case of a patient who had a pretty classic sounding vasospastic event on 5FU for advanced pancreatic cancer. So it was recommended to pursue alternative therapies, but ultimately she had progression of disease on all available lines of therapy other than 5FU based lines. And so, we had a shared decision-making discussion with her and her oncologist. And she really was very concerned about her cancer progressing. This was her biggest priority. And so, we recognized that there was a risk of recurrent vasospasm, but we did imaging on her to make sure that there wasn't anything else potentially contributing. So we had a coronary CTA that showed some mild non-obstructive coronary disease. We aggressively augmented her vasodilatory medications to prevent vasospasm. And we recommended that if it had to be resumed, and if this, if she understood that there was an increased risk, it should be done with very close clinical monitoring in an inpatient setting, ideally with telemetry, so that if she were to develop vasospasm, we could intervene, we could recognize it and intervene sooner rather than later. So she ultimately chose to pursue that route. But again, others might choose differently, because they're really, there's a risk of withholding therapy, obviously progression of disease, which is a lethal event in this case, and vasospasm can also be a lethal event. So, it's not always up to us. Obviously we need to weigh in, but the patient priorities are a really key part of this decision-making here. And so in the final sort of context, when we're thinking about cardiovascular benefit versus cancer risk, when patients are actively dying from advanced malignancy, withholding aggressive cardiac intervention does seem pretty straightforward. But as the landscape of cancer therapy is rapidly evolving, particularly with the advent of immunotherapy, even patients with metastatic malignancy may have life expectancy of well over a year. Of course, they still may be at higher risk of complication or less likely to benefit from certain interventions, but I think it's really important because in the past, and I think many of us who practice in this field have experienced this, that there may be a lot of perhaps undue reluctance on the part of interventionalists or surgeons to intervene on patients with metastatic malignancy because of a misperception that they have a very limited life expectancy, when in fact this isn't always the case. So it's really important, again, to have those discussions, not just with patients about their priorities, but also with the oncology team about what the actual prognosis for these patients is. So, take, for example, patients with brain metastases. In those patients, dual antiplatelet therapy probably is going to pose a higher bleeding risk. And so medical management might be better than PCI. Similarly, patients with limited life expectancy due to cancer, but a preserved quality of life other than refractory angina probably would benefit from PCI, even if they have multivessel disease that otherwise would make CABG seem more appropriate. So again, these decisions are really going to be best shared among cardiologists, oncologists, and patients. And we should try to avoid one-size-fits-all or unilateral decision-making, because this runs the risk of either denying patients cardiovascular care that could benefit them, particularly if their cancer mortality risk is overestimated, or on the other hand, pressuring them into undergoing cardiovascular interventions that may only put them at risk of further complications while undergoing cancer treatment. So I think just in closing, I think it's helpful to, I've put together a list of questions that I think are helpful in sort of prompting these discussions with patients to really interrogate what their values and priorities are and inform the shared decisions that we make with them. So these include, are you more worried about your cancer or your heart condition? Which is more important to you, longevity and survival, functional status and quality of life, or comfort and avoidance of pain and suffering? Do you prefer a less is more approach, or rather a make sure all bases covered approach? Or do you fall somewhere in between? Do you favor lifestyle interventions to minimize medications, or is it easier for you just to take medications because of other challenging circumstances? And similarly, questions for us as clinicians to consider when we're going into these discussions and thinking about decisions that are often challenging. Which poses a greater threat to the patient's survival and quality of life, cancer or heart disease? Is long-term survival a realistic goal, or would a shift in goals of care to focus on quality of life be more successful in your clinical opinion? What is the risk-benefit ratio of proposed interventions from an oncologic and cardiac standpoint, and how might they conflict with each other? And finally, to what extent might lifestyle interventions supplant the need for pharmacotherapy, and how willing and able might the patient be to adopt these lifestyle changes? Thank you again for your time, and I'd be happy to take any questions now or save them for further discussion in the panel at the end, based on everyone's preferences. So we can make a shared decision about that too. Thank you.
Thank you, Sarah. Excellent presentation. There's one question. It's not easy to have a perfect balance of individual choices in this complicated medical decision-making process, because most physicians tend to be very aggressive or patient at the beginning, yes, and then you guide them as their disease progress to the later stage.
Mm-hmm. Yeah, it's not easy, and you're right. A lot of us are sort of operating under the assumption that, that the burden of making the decision is on us. And to be clear, it is to a certain extent that we shouldn't just be pushing a lot of hard decisions onto patients. But I think it's also important to realize that where that balance lies, even that in itself will vary from patient to patient. So some patients are, they'll say, well, doc, you're the boss. Like, whatever you want to do, whatever you recommend is fine. Just tell me what you think and I'll do it.
We love these patients.
I'm sorry?
We love these patients.
Yeah. It's funny. I always tell them, well, I'm the expert, but you are the boss. And ultimately, like, you have to be okay with everything that I'm recommending to you. Because I really do think it's important that we empower patients to take a role in their decision-making without, again, pressuring them to make decisions, because sometimes they find that very burdensome and they just want us, they'll say, what would you do if it were you? What would you do if it were your loved one? And usually I'm very happy to make recommendations in those cases. And often if we take the time to listen, we can sort of glean that information from a patient just based on how they describe their process with the disease, how they're dealing with it. And this underscores another really key ethical principle in my opinion. It's not one of the pillars that we learn about in medical school, but it's something that I've done work on, which is the issue of the importance of time and not conflating speed and efficiency, because these patient visits require more time than a classic general cardiology visit. And we really shouldn't underestimate the therapeutic value of time spent and just the value of listening and being heard. But also really, we can learn a lot from patients in the time that we spend with them. And we can be much more effective in counseling our patients and developing relationships and engendering trust with our patients when we take a little bit more time. And so it's, there isn't this one size fits all approach, obviously. And some patients want, they want to be involved in every tiny decision, and they want to hear your detailed rationale for every medication you're choosing and why, and that's fine. And then other patients really don't want to hear it, and they're, you tell me what you think is best and I'll do it. And, all of those approaches are really reasonable. And I think if we have some patience and really listen, we can glean a lot from patients, even without asking them directly. But I think it's helpful to use these questions as launching points when it's not always clear. And often that can help to engender, really, really productive discussions that can help us decide how we're going to move forward.
Thank you, Dr. Hall.
Thank you so much.
Our next speaker is Dr. Mina Olier. She's the director of Cardio Oncology at Stanford Hospital, assistant professor of medicine, Columbia University Medical Center. She attended medical school in George Washington University School of Medicine, in a residency, University of Pittsburgh School of Medicine, and a cardiology fellowship at New York University Medical Center. Dr. Olier has a very large practice of cardio oncology patients here.
Okay, thank you so much. Hopefully you can hear me.
Yeah.
Okay, great. So I'm switching gears completely and talking about assessing cardiovascular risk in multiple myeloma. And this is, in a nutshell, basically boiling this down to 10 minutes, but was inspired by some complex patients that I had. And I would just say to Dr. Mom's point earlier, so much of cardio oncology is learning on the job. So I'm very grateful to, be a part of this tonight and learn from all of you experts. So this is again oriented towards, I'd say, the general cardiologist. No disclosures. So bottom line, these are a very complex group of patients, and cardiovascular events are very common in multiple myeloma. And this is likely due, as in much of the oncology population, to a combination of factors from a high prevalence of pre-existing cardiovascular comorbidities, increased cardiac risk from the actual disease burden of multiple myeloma, and certainly related to the treatments that are administered. So just as a brief review, multiple myeloma is a plasma cell malignancy, and it is characterized by a clonal proliferation of malignant plasma cells in the bone marrow, which result in excessive amounts of immunoglobulin, which can collect in various organs and lead to end organ dysfunction. It accounts for about 1 to 2% of all cancers and around 13% of hematologic cancers, and is predominantly a disease affecting elderly individuals with a median age, a diagnosis of around 69 years, increasing with age, and also higher in Black individuals. And the exact cause is not really well known, but risk factors can include obesity, male sex, and certain occupational exposures. Agent Orange, firefighters, 9/11 survivors seem to be at higher risk. And thanks to really increased diagnosis and more modern therapies for myeloma in the past, and really 15 years, particularly with stem cell transplant, patients are living longer and have a median survival of 5 to 7 years. And with even more novel therapies, many are living past 10 years or more. So again, as a result, management of cardiovascular comorbidities and the toxicities related to the therapies are becoming increasingly important to just improve clinical outcomes and promote a healthy survivorship. So these are the criteria we remember from medical school, and very much relevant again to the cardiovascular toxicity, but we know that the disease is marked by hypercalcemia, renal insufficiency, significant anemia, and lytic bone lesions, as well as a percentage of the plasma cells and ratio of light chains. So patients with multiple myeloma, as I referenced before, do have more cardiovascular disease at baseline. About 2/3 of individuals are coming into the disease with known cardiovascular, either prior events or comorbid conditions. And again, this is related to the fact that this is an older population, male, obesity being a risk factor again. But if you look at large registry data, the prevalence of hypertension is upwards of near 40%. And a significant portion of those patients will develop really malignant hypertension over, just a few years follow-up compared to non-myeloma patients, again, probably related to treatment. A large portion have arrhythmias, ischemic heart disease, and diabetes. Interestingly, I thought actually there's a reduced prevalence, even though obesity is so high, of dyslipidemia, and that's thought to be secondary to increased clearance of cholesterol by the cancer cells for growth and proliferation, and that seems to be reversed after treatment. So the burden of multiple myeloma, and again, knowing those clinical presentation of myeloma actually increases cardiac risk directly. So we know that hypercalcemia is linked to the development of arrhythmias. Renal insufficiency is a well-known cardiovascular risk, and anemia has multiple mechanisms that can increase cardiovascular risk, from arrhythmia to heart failure and ischemia in a susceptible patient. Myeloma itself it can lead to hyperviscosity by the elevation of circulating immunoglobulins, and that's associated with microthrombi, coronary microthrombi, and heart failure. And somewhat more rare could be high output failure from multiple bone lesions secondary to AV shunting. Probably the most common direct consequence of myeloma that we really need to think about in all of these patients is the association with AL amyloid. So 12 to 15% of patients will have clinical amyloidosis. Up to a third of those patients have subclinical amyloid deposits, but most importantly for us, we know that cardiac involvement is present in more than half of patients with AL amyloid, and really the prognosis of that is determined by the extent of cardiac involvement. So something that has to be on our mind for all patients with myeloma, and we know that this starts as a restrictive pathophysiology and heart failure initially with the preserved LV function. The other major consideration for direct effect of myeloma on the cardiovascular system is related to thromboembolism, both arterial and venous. And again, while arterial thromboembolism may be in part related to some of the risk factors, age, et cetera, this incidence of higher arterial thromboemboli, MIs and strokes also seen in younger patients with myeloma, even at an average age of less than 60, with an incidence of about 5.5%. So that's certainly a consideration coming into treatment. Now, multiple myeloma is also an independent risk factor for venous thromboemboli, and there are likely multiple mechanisms involved with this related to endothelial dysfunction and platelet activation, the hyperviscosity, as we mentioned, which increases fibrin and also seems to trigger protein CNS deficiencies. We know that the bone marrow stromal cells can secrete inflammatory cytokines. And certainly a big part of this, which I'll touch upon in one moment, is related to specific therapies, the immunomodulatory drugs that we give for myeloma, and particularly in combination with dexamethasone and other chemotherapy can dramatically increase the risk of venous thromboembolism. So switching gears to, again, the third component is the increase in cardiovascular risk from the treatments that are given for myeloma. So there's really been a paradigm shift in the past 15 plus years for the treatment. And now there are extremely effective, excellent response rates with initial therapy, and the survival has really improved due to increased use of stem cell transplant and also the introduction of immunomodulatory drugs and proteasome inhibitors, which are essentially first line for newly diagnosed myeloma patients in both transplant and non-transplant eligible patients. So something that, again, as cardiologists, we have to become comfortable with. The patients often will have a full portfolio of drugs that they've used over the years. And we know that stem cell transplant survivors alone have upwards of a fourfold increased risk of cardiovascular effects compared to the general population. So again, this might be due to the incoming risk factors, but also due to the conditioning regimen that patients will receive and the portfolio, again, of agents that are used that have particularly specific cardiovascular toxic effects. So we know that over 70% of patients with myeloma are going to develop a cardiac complication during their treatment over a 6-year period. And obviously that can be heterogeneous. So the important classes, I think, for us to remember as cardiologists really are the immunomodulatory agents, lenalidomide and pomalidomide, mainly because of the risk of arterial and venous thromboembolism. These both carry a black box warning, and patients need to be risk stratified and started on antiplatelets or anticoagulants, depending on their risk. So this is pretty much considered a standard risk stratification, usually done, again, by the oncologist upfront when starting treatment. But essentially what we're looking at are individual risk factors, many of which I had touched upon, the cardiac comorbidities, immobilization, prior surgeries, obesity, myeloma-related factors in terms of the disease status and hyperviscosity, and then therapy-related risk factors, particularly high-dose steroids, concomitant use of erythropoietin, and again, the use of lenalidomide or pomalidomide. We need to basically look at this and decide whom should be, if really you have less than one of those factors, be on aspirin, and everybody else to be on low molecular weight heparin or warfarin, at least for the duration of the treatment, 4 to 6 months of treatment, or at least until the disease is controlled, because again, the risk is so high. The proteasome inhibitors really has received most attention, certainly with concern for cardiotoxicity, mainly with carfilzomib, Kyprolis. And the proteasome inhibitors are a cornerstone in multiple myeloma management and have really contributed substantially to the improvement in survival. And they were compared head to head in the Endeavor study. And what it seems to be is that while bortezomib in the big studies has not really shown marked cardiovascular toxicity, there are a number of case reports that do support this could be a potential risk. But without question, carfilzomib seems to have the highest risk of cardiotoxicity. And the mechanism, is not completely understood. We know that proteasome inhibitors are binding to the 26S proteasome and causing accumulation of byproducts within plasma cells and then cause apoptosis. But unfortunately, off-site effect is on the normal cardiomyocyte where the proteasome system is also involved and probably leads to, again, misfolded proteins, oxidative stress, and endothelial effects, which is why we see so much hypertension and vascular dysfunction with some of these agents. So again, carfilzomib is known to be associated with increased risk of cardiac events. The initial studies, really when it was first approved, showed very high rates. Around 22% of patients in these early trials had cardiovascular events. And this is probably because these patients were heavily pretreated, they had advanced disease, and the carfilzomib was used as a single therapy. But subsequent trials have shown a slightly less, around 18% of patients experiencing cardiovascular adverse events. Again, hypertension being extremely common, heart failure, ischemic events, and pulmonary hypertension as well. Many patients, up to 30%, will experience dyspnea, and about a quarter of patients will have edema. So the majority of events seem to be early effect with the highest incidence associated with the first cycle. And again, just as cardiologists, we need to be aware of these toxicities and really work closely with the oncology team to surveil the patients while they're undergoing treatment, particularly those with a baseline high risk. The Endeavor trial had an echo sub-study and basically showed, again, that it was really the Kyprolis that had high rates of heart failure and pulmonary hypertension, and that when an LV reduction, EF reduction was seen, that this is generally reversible. It was dose-related. But interestingly, between the Velcade and the Kyprolis, there was no major difference in the ejection fraction. So this supports the idea that a large portion of the heart failure is actually diastolic dysfunction. So this is a general table that was taken out of the chart that's taken from the ESC regarding monitoring in all cardio-oncology patients, but I think this mantra holds true certainly for carfilzomib. And basically what we need to do is figure out who are the patients that are at high risk for cardiotoxicity with this agent. And these are the patients that have known histories of cardiovascular disease, hypertension, arrhythmias, poorly controlled hypertension in particular. And those patients arguably could benefit from cardiology input upfront to optimize and manage these comorbid conditions. And again, to help with monitoring volume status while receiving this medication, and also to consider the use of aspirin upfront for many of these patients. So I think most centers would obtain in these patients, although it's not necessarily guideline, baseline at least echocardiogram and BNP to follow throughout the treatment. So fortunately, again, temporary interruption can be sufficient if there is a cardiac event, and usually patients can resume at if needed, a lower dose. In some patients, though, if heart failure persists, that's when we again need to think back to if cardiac amyloid has been missed. And this is just, again, another nice summary from the recent ESC guidelines that help us identify whom are the patients that will receive either proteasome inhibitors or immunomodulatory agents for their myeloma that are at higher risk to develop the cardiovascular events. So again, just to summarize, fortunately, miraculously, the outcomes for myeloma have really improved in the recent years. And we know that patients with myeloma are at very high baseline risk with a high burden of comorbid conditions. They're susceptible to cardiovascular events from myeloma itself and the multiple effects it can have on various systems. And it's obviously very prudent to observe these patients closely between cardiology and oncology to optimize their cardiac status while they're receiving these potentially cardiotoxic drugs. So that is all. Thank you very much.
Mina, for a superb presentation. The one issue we are struggling with is the cost of medication treating cardiac amyloidosis. There seems to be an obstacle for optimal treatment. What the pro can share with the audience about this issue?
Are you speaking specifically about TTR amyloid and agents?
Right.
Pearls. I don't know that I have the solution. The truth is that that's been a major barrier, and we've had to collaborate closely with our specialized pharmacy, and that's been a legitimate challenge for many patients. On the TTR amyloid discussion, the other thing I struggle with is really in the older population where we have a suspicion for TTR amyloid and deciding in whom we should be really pursuing PYP scans and further evaluation and potentially a very, very expensive drug with, I guess, an unclear benefit in that older population. So I'm not sure that I have the answer to that. Unfortunately, it's this exorbitantly expensive medicine.
Thank you. Dr. Clover has a question for Dr. Hall earlier.
Hi, everyone. I'm really enjoying this meeting, by the way. Dr. Sai, thank you, but maybe we can just talk about it in our final wrap up so we don't go back and forth. I mean, that's fine.
Okay.
David, if I may ask a quick question. That was great, Aliyah. Just one brief question. You mentioned about in patients that are getting immunomodulatory agents with multiple myeloma and assessing their risk factors and deciding about antithrombotic therapy based on that. I didn't see DOACs listed as an option. I was just wondering if there's any observational data or practice in real world. Are people using those rather than what's in the warfarin, for example, as an option?
My understanding is that it is not known if the DOACs are adequate for prophylaxis. Certainly, and in oncology, please, if anyone knows better, certainly in the real world, I've seen it used. And again, certainly with patients that have developed clots in the setting of these agents, then they're being treated with DOACs. But as far as I understand, the recommendations are low molecular weight heparin or warfarin for prophylaxis.
Thank you.
Next presenter is Dr. Joseph Nanaraj. He graduated Bridgeport Hospital Cardiology Fellowship, and he joined a practice in St. Mary. He has a hands-on in cardiology, interest in cardiac imaging. Dr. Nanaraja will be presenting cardiovascular side effects of Bruton TKI, a case-based discussion. Welcome, Dr. Nanaraja.
Well, thank you, Irma, for your kind introduction. Are you able to see my screen?
Not yet.
Not yet.
While we're waiting for Dr. Nanaraja to get the screen up, I do have a question for the panel. As far as cardiac biomarkers, how often do you use them and when do you use them? European Society of Cardiology has come up with clear recommendation as far as what type of patient we use them and how often we follow them. But how about here? What is your experience here? And Dr. Oligia, since you talked about them.
I think certainly we use them frequently. It depends, of course, on the let's say the therapy of the chemotherapy regimen that's being used. But as I think Eric had mentioned, so frequently we see patients with somewhat nonspecific complaints, dyspnea, fatigue. And I find that, in addition to our clinical acumen, it's another level of reassurance if we have a baseline and we, can monitor that whenever we're seeing the patients and they might be complaining of these sort of issues. I find that the oncologists also here order them up front as well. I think they're very much following the guidelines. So I often see that they're coming already. Perhaps they've had an abnormal strain, abnormal echo, and upfront the oncologists have ordered the BNP and troponin. So I would say we use it very frequently.
I would agree with that. With everything that you just said. A particular indication where I think it can be helpful, especially with the high sensitivity troponins, because those are almost never totally normal, is getting a baseline before patients start immunotherapy. Because if then you're concerned about myocarditis, you check a troponin and it's like a hair positive, but it might have been normal on one of the earlier generation assays. It's really hard to know what to do with it. So I'm a fan of getting baseline biomarkers really before any potentially cardiotoxic therapy, but I think particularly it can be useful in immunotherapy for like anthracyclines and TKIs and HER2, anti-HER2 therapy. Typically, unless a patient's really high risk, if they start off with a normal echo, normal biomarkers, and they don't have any symptoms and their serial echoes are normal, I don't think there's as much as a role for also, an additive role for biomarkers, and that's reflected in the guidelines for ESC. So, I would say though baseline is more helpful than serial monitoring in many cases, just so that if you then get stuck and now you suspect toxicity, you have a comparator, particularly now with the high sensitivity tropes that I can see a lot of nodding when I said that. So I think a lot of us are in that boat.
Thank you.
All righty, can I take over?
Ready? Yeah.
All righty, thank you. So I chose this case because it deals with a common problem we encounter every day as a clinical cardiologist. And it also gives me an opportunity to talk about the drug-to-drug interaction with this common chemotherapeutic agent, which is used in particularly in CLL, and the drugs which we use for atrial fibrillation. So the case, she's an 81-year-old female who came in with palpitations, and she has a history of hypertension, prediabetes, dyslipidemia, non-obstructive coronary artery disease, who came to the ER with palpitations for 6 hours. She had dyspnea the night before, and she denied chest pain, orthopnea or leg swelling. And she's an ex-smoker, and she enjoys a glass of wine with dinner. And her current medications are aspirin 81 milligrams daily, rosuvastatin 20 milligrams daily, lisinopril 20 milligrams daily, mirbitriq 25 milligrams daily, and ibrutinib 420 milligrams daily, which is the Bruton tyrosine kinase inhibitor, which we will talk about soon. And on exam, her blood pressure was 150 over 78 millimeters of mercury. Her heart rate was 140, irregular rhythm. Her respiratory rate was 16, saturating at 96% on room air, and her weight was 68 kilograms. And on auscultation, her chest was clear, and exam of the heart showed demonstrated variable S1 intensity, grade 3/6, early peaking systolic murmur in the aortic and left parasternal region. And she had a splenomegaly, and on extremity, she had no pedal edema. Her labs, her BUN of 28, creatinine of 1.2, potassium of 3.8, MAG of 1.9, WBC count of 18,000, platelet count of 112,000, hemoglobin of 9.8 grams per deciliter. Her D-dimer was normal for her age. Her BNP was 780. And her echocardiogram showed normal LV systolic function. Her RV size was normal, and she had a mild biatrial dilatation, and she had mild aortic stenosis and mild to moderate MR, and her global longitudinal strain was -19. So I'm going to shift gear and talk about the Bruton tyrosine kinase inhibitor, and we'll circle back to the case again. So Bruton tyrosine kinase is a signaling molecule in the B cell receptor pathway which is implicated in the B cell lymphomas such as CLL, follicular lymphomas, mantle cell lymphomas, and Waldenstrom's macroglobulinemia. So the common drug is ibrutinib, acalabrutinib, and zanubrutinib. The common cardiovascular side effects are atrial fibrillation, which happens in 5 to 15% of patients who receive this drug, ibrutinib. And depending on how long they are followed up in the studies, the incidence could vary from 5% to 25%. Okay. The other common side effects are ventricular arrhythmia, sudden cardiac deaths, and 60 to 80% of these patients who receive this drug, ibrutinib, develop hypertension at some point. And there is also increased risk of bleeding due to its inhibition of platelet activity. So most of the side effects, particularly the cardiovascular side effects of the BTK inhibitors, are caused by inhibition, off-target inhibition of the phosphoinositide 3 kinase pathway inhibition, which is responsible for a lot of cardiac effects. So as you see here, PI3K inhibition causes increased late sodium current, causing early after depolarization, and increased L-type calcium current, which causes delayed after depolarization, and alpha adrenergic stimulation causing myocardial dysfunction. So it also predisposes to polymorphic ventricular tachycardia, but it does not cause QT prolongation in these patients. And it also acts on endothelium, causing hypertension, and it inhibits the activity of von Willebrand factor, collagen, and fibrinogen, causing increased bleeding. So as I alluded before, the incidence of AFib is 5.77 per 100 person years over a median follow-up of 18.3 in one study. But some of the studies recently have shown an increased incidence of up to 25% during a longer follow-up up to 3 years. And median time to AF onset is around 2.8 months. Risk factors for ibrutinib-associated AFib are prior history of AFib, age more than 65 years, pre-existing hypertension, and high Shanafelt score in CLL. So Shanafelt score is a risk score to assess the risk of developing AFib in patients with CLL receiving ibrutinib. So of interest is the drug-to-drug interaction. Some of the drugs which we commonly use, like the calcium channel blockers, increase the plasma levels of ibrutinib by 6 to 9%, thereby increases the risk of intracranial bleeding. Again, digoxin level is increased because of the ibrutinib's inhibition of P-glycoprotein. And also, ibrutinib inhibits this CYP3A4 and increases, CYP3A4 is inhibited by amiodarone and dronedarone, causing increased plasma level of ibrutinib, increasing the risk of bleeding again. And use of DOAC is also fraught with complications such as increased bleeding because of ibrutinib's interaction through the CYP3A4 pathway and the inhibition of P-glycoproteins, particularly dabigatran. So management of AFib in patients with AFib in patients who is receiving BTK inhibitors. If the patient's CHA2DS2 score is low, you continue the ibrutinib and without using aspirin or DOAC. And if the patient has CHA2DS2 of 1, based on clinician's preference, you can use aspirin. Or if the patient starts to ask score is more than or equal to 2, ibrutinib can be continued if there is no risk of bleeding with the DOAC, or if the patient has an increased risk of bleeding, it is advised to reduce the dose of ibrutinib by 140 milligrams per day. And still, if the patient starts to bleed, you could consider stopping the medication or decrease the dose by 140 milligrams. So you can reduce the total dose up to 280 milligrams when you combine the ibrutinib with DOAC when there is increased risk of bleeding. And in patients who had a recent stenting or who needs DAPT, it is recommended that the patients stop ibrutinib so that the DAPT can be continued along with DOAC. And preferably the DAPT should be, the dual antiplatelet agents should be stopped after, aspirin should be stopped after a month, and the P2Y2 inhibitors can be continued after a month along with the DOAC. And then ibrutinib can be considered to, you can reconsider starting the ibrutinib. And so clinical questions with regards to our patients, should we use rate control or rhythm control? So we preferred rate control in this patient because we thought it will be difficult to attain sinus rhythm in this patient or maintain sinus rhythm in this patient, given the fact that we were planning to continue ibrutinib. The oncologist was planning to continue the ibrutinib. So, and then again, the drug-to-drug interaction between ibrutinib and the drugs which we commonly use to treat AFib for rhythm control will interfere with ibrutinib. So hence we prefer rate control in this patient. And the drug of choice, we use beta blockers for rate control rather than calcium channel blockers because of its interaction with ibrutinib. As I showed in the previous slide, diltiazem and verapamil increases the ibrutinib level 6 to 9-fold and increases the risk of bleeding. And in this patient, we decided to stop the aspirin because she was taking aspirin for non-obstructive coronary artery disease. And we thought the risk of bleeding is higher with the combination of aspirin with ibrutinib and the DOAC. And the DOAC of choice we chose was Eliquis. And we are debating between 2.5 milligram twice a day to 5 milligram twice a day. Given her age and her creatinine of 1.2 and her weight of 68, we decided to go with 5 milligram twice a day while carefully monitoring for side effects such as bleeding. And to continue or discontinue ibrutinib, we decided to continue the ibrutinib in this patient because she was responding to ibrutinib with reduction in splenic size and improvement in hemoglobin. So, and this is a summary of the recommendation from the ESC guidelines. They recommend BP monitoring in these patients at every clinical visit. And they also recommend home monitoring of blood pressure because these patients develop hypertension. There is an incidence of 60 to 70% development of hypertension in patients who are getting this therapy. And baseline echocardiography is recommended in high-risk patient. If you suspect the patient is at risk for atrial fibrillation, they recommend, but the level of recommendation is class C. And it is recommended that we use every opportunity to screen for AFib during the clinical visit. All right, thank you.
Thank you for sharing the experience.
Joseph, how would you do the screening? Do you, it's recommended to do electrocardiograms each visit or clinically?
Yeah. The recommendation is to do an ECG during each visit and by pulse checks.
I have to say that BTK inhibitors, thank you very much for sharing the experience. This class of medication can be of challenge if you have any cardiac issues, particularly already has a risk of AFib, and management of AFib if they're taking these medications can be fraught with the problems. So yeah, I think like your last sentence of consider alternative therapy. if necessary, or adjust the therapy like you did.
Our last presenter is Dr. Neil Fishback.
I think Dr. McPherson has a question.
I can wait until the panel discussion and I'll then raise my points. Thanks.
Okay.
So Dr. Fishback got his medical degree from Harvard, and then he went ahead to University of California for his residency and fellowship. He's currently Associate Medical Director to the Clinical Trial Office on the network in Yale New Haven Health Network. He runs a weekly fantastic breast tumor boards that I was lucky to participate. And he's gonna talk today about advancement that warm the heart clinical development in breast cancer therapy. Hopefully in our future conferences, we'll be able to endorse more oncologists, but he's the first one in our meeting. So welcome, Dr. Fishback.
Thank you. Dr. Nataraj, if you could unshare your screen, then I'll share. Thanks. Terrific, thanks. So, wow, really honored to be here today with such an esteemed panel. And boy, as you can tell by the format of my first slide, not only are cardiologists much better dressers than oncologists, but your slides are formatted much better as well. All joking aside, I think cardiologists have a kind of mythical status in the hospital interactions, striding into rooms in times of crisis and fixing problems. And nowhere is this more apparent in cardio oncology, because we create a lot of mischief with the drugs we use that have very narrow therapeutic windows. And we so appreciate that group of cardiologists that has now become a very active and what I think really fascinating subspecialty, has decided they want to make this their passion. And also those cardiologists who joined in tonight, general cardiology, just want to make themselves more knowledgeable about the intersection of cardiology and oncology. And I have no disclosures. I'm really going to focus on two themes, two areas of advancement within the last year in breast oncology, which have prominent overlap with oncology. And one of them is immune therapy, which Dr. Baldassarre has already highlighted it so well. And then we're going to talk a bit about antibody drug conjugates, specifically anti-HER2 antidrug conjugates, which Dr. Oligino had also really eloquently begun to elucidate some of the toxicities we can run into. Well, why in the world do we use immune checkpoint inhibitors when they cause so many problems? Well, cancer cells have this bad habit of overexpressing the programmed death ligand, which when bound to the programmed death receptor on immune effector cells, even in the presence of tumor antigen T-cell receptor interaction, puts the T-cell to sleep and does not allow effective immune activation. And now we have many medicines which can both bind to PD-1 or PD-L1 and disrupt this negative interaction, and thus lead to really profound anti-tumor effect. We're going to look at some of that data in a second, but I think it's worth acknowledging right from the outset that unfortunately the vast majority, roughly 85% of breast cancers are what are considered immunologically cold. That is not sensitive to our currently available immune checkpoint inhibitors, while triple negative breast cancer, which makes up about 15% of all breast cancers, can be immune active. So this data was just published this year. This is data from the Keynote 355 trial, which combined taxane chemotherapy with a very commonly used immune checkpoint PD-1 inhibitor, pembrolizumab. And when used in patients that have elevated PD-L1 expression, as measured by a measurement called the combined proportional score. It's a proportion of tumor cells and immune cells within the tumor that are positive over the total number of cells, produced actually a very striking improvement in survival. And this addition of pembrolizumab resulted in roughly an 8-month improvement in median survival, decreased the risk of dying by about 25%. So a pretty large advancement, and now pembrolizumab has become standard therapy for those with triple negative breast cancer and a tumor combined proportional score that's over 10%. And as we are wont to do in oncology, once we discover that a drug is active in the metastatic setting, the next step is take it to the early or curative setting and see if we're able to cure more patients. And early data from the Keynote 0522 trial was also published within the last year, which added pembrolizumab to actually a very intensive neoadjuvant chemotherapy regimen of adriamycin and Cytoxan together with carboplatin and Taxol. And in that regimen, the carboplatin and Taxol is given concomitant with the Keytruda, as is the adriamycin and Cytoxan. And this study in early data where we have event-free survival, but not quite yet overall survival, again showed a really prominent improvement in what we hope will be cure rate with the addition of pembrolizumab. What also seems to be a really interesting theme in immune therapy is that in the metastatic setting, particularly in the previously treated metastatic setting, expression of PD-L1 appears to be an important predictor of response to immune therapy, and that appears to be much less the case the earlier you get in the cancer treatment, and in particularly in the untreated setting like neoadjuvant or adjuvant. So pembrolizumab activity is independent of PD-L1 expression, and that's not a criteria for use. But as we know from taking care of patients with autoimmune conditions, once you start messing with the immune system and stimulating the immune system, that is a double-edged sword where you can get all kinds of toxicities in every organ and tissue in the body. And of course, today we are focusing on the cardiac toxicities. And I'm sure you all are aware in the recent October Journal of Clinical Oncology, there were two back-to-back very large reports of immune checkpoint inhibitor toxicity on the heart. And the one I chose to focus on is the one that involved the cancer therapy evaluation program. Essentially, any clinical trial is run through CTEP. And they looked at their cumulative experience with just about 7,000 patients who had gone on trial with either single agent or combined immune checkpoints with or without chemotherapy. And they found that of those patients, there were 40 that had a verified major adverse cardiac event. 170 seed potential, but a lot were adjudicated as not definitely due to the immune checkpoint inhibitor. So this is like the most stringent criteria. There were two cardiologists who poured through the chart and decided that yes, that is confidently a major adverse cardiac event related to the immune checkpoint inhibitor. And these included the full spectrum of cardiac toxicities, but most notably, the largest criteria was myocarditis. And that strikes fear in the heart of every cardiologist, and why we are extraordinarily grateful for our cardiology colleagues. These cardiac toxicities happen pretty early. This is the median time for all major adverse cardiac events and myocarditis. So really within 2 months, the majority of people may manifest evidence of these toxicities. And importantly, these toxicities, as I'm sure you all realize, are a big deal. Of these 40 patients, 93% resulted in hospitalization, a full 22.5% resulted in death. And I think that early recognition of significant myocarditis, institution of appropriate therapy, these are things that oncologists struggle with, are often sometimes afraid to ask for help. But we are really in need of close collaboration, guidelines, and guidance in how to identify and treat those conditions. We'll come back to that theme towards the end and hopefully in the discussion. But in the last 5 minutes, I just wanted to segue a bit to antibody drug conjugates. So we're all familiar with the miracle of our immune system and antibody formation and the myriad ways in which antibody binding to infectious particles can activate our immune system. Well, the same is true for anti-cancer antibodies. And the paradigm for this was trastuzumab. So trastuzumab was the first molecule, antibody molecule approved for treatment of a solid tumor, and it builds on the concept that the HER2 receptor is a ideal target for antibody therapy. There's a high concentration on on the surface of tumor cells. There's a low presence on normal cells, with the notable exception in the heart, where true there are low expression but meaningful expression. And it's important to the function of cancer cells, and in quotations, I should say, not critical for the function of normal cells unless you're a myocyte. And this is some of the early data that led to the approval of trastuzumab. Again, this is near miraculous stuff in patients with metastatic HER2 positive breast cancer, with dramatic improvement in median survival. Unfortunately, not curative. But again, as is our trend, once demonstrated to be markedly effective in the metastatic setting, this was data which led to a standing ovation at our American Society of Clinical Oncology meeting, that when you combine anti-HER2 monoclonal antibody therapy with standard risk-reducing chemotherapy to patients who've had curative treatment for their disease, you increase the cure rate from what had been the highest risk subset of breast cancer patients, the 67% cure rate, up to 85%. So that was a really dramatic innovation, actually instantly catapulted HER2 positive breast cancer from the highest risk subset of patients with early breast cancer to the most curable, and in fact led to us having to change our staging system. So now patients with even node positive HER2 positive breast cancer are considered stage 1 or highly curable. And this trastuzumab as a target, HER2 as a target for therapy is now spilling over into other solid tumors. So you may be called to consult on patients with gastric cancer with cardiac toxicity related to anti-HER2 treatment. The dark underbelly of all this is that in this initial seminal study of trastuzumab to reduce risk of breast cancer recurrence in combination with chemotherapy, the rate of class 4/3/4 CHF was a pretty sobering 4.1%. Of these 31 patients, 30 recovered to be asymptomatic. But again, as Dr. Olagino had highlighted, asymptomatic does not mean a full recovery of ejection fraction. So the next step in the evolution of antibody therapy is antibody drug conjugates, which really is the Trojan horse of oncology. The idea that we are using a monoclonal antibody to not only bring chemotherapy molecules to cancer cells, but actually get those chemotherapy molecules taken up by the cancer cell and then selectively released inside the cancer cells. And Paradigm, the first molecule that really demonstrated the power of this treatment was trastuzumab emtansine, in which it was the same anti-HER2 antibody trastuzumab, but to it was linked emtansine. Now, emtansine is a microtubule inhibitor that washed out of the chemotherapy world because it was far too toxic. But when you stick it onto the back of an antibody with this magic linker that maintains the toxin attached to the antibody until it is inside the cancer cell and cleaved in the lysozyme, then magic happens. And so trastuzumab emtansine is so hard to say, many people just stick to its brand name, Kadcyla. But Kadcyla binds to the HER2 receptor. It is endocytosed. Inside the lysozyme, the billion-dollar linker is cleaved, and then the emtansine seeps out into the cell and exhibits its cytotoxicity. And very similar to trastuzumab monotherapy, Kadcyla was first used in folks with metastatic HER2 overexpressing breast cancer. And HER2 overexpressing breast cancer, again, is similarly about 10 to 20% of all breast cancer. And in this population of heavily pretreated patients with relatively limited therapeutic options, treatment with Kadcyla significantly prolonged overall survival. And thus, next step again, these are patients with early curable HER2 positive breast cancer, but these are patients who already have received trastuzumab containing risk reducing treatment before surgery, and then have surgery and are found to have residual disease. And we recognize that if we are unable to eradicate all the disease in the breast and axillary nodes, after neoadjuvant trastuzumab containing chemo. That's a group of patients that has a pretty substantial risk of recurrence over the next 5 years, risks that are in the 15% or higher range. And in this super high risk group, just tweaking that maintenance from trastuzumab alone to Kadcyla for 14 doses dramatically improved, a full 10% improvement in cure rate. And that was a major innovation. We've evolved from trastuzumab emtansine. So our first generation of antibody drug conjugates required a high target expression on the tumor cell in order to get adequate toxin into the target cell. Only 3 molecules of emtansine per antibody, and so you got to get a lot of it onto the surface of the cells. And moreover, all cancer cells needed to express the target because the toxin is released ideally only in the cancer cell. Our next generation of antibody drug conjugates have allowed us to target cells that have low level of target expression. We're using even more potent payloads and finding ways to stick more of these chemo moieties onto each antibody. And moreover, what you might think is a negative impact turns out to be a positive, that these toxin payloads are a little bit leaky, and they can leak out of the cancer cell and treat bystander cells, which may not express the target. And the darling of this, or I should say the model for this next generation is trastuzumab deruxtecan, which is otherwise known as Enhertu. And the salient features of this molecule is there are 8 molecules of deruxtecan attached to each trastuzumab antibody. It's a topoisomerase DNA damaging, highly potent payload. And most importantly, it's a little bit leaky. It can get out of the tumor cell and treat bystander cells. And so again, this is how it does its thing. It binds to HER2, gets inside the cell, cleaved in the lysosomes, but then can sneak out and treat nearby cells. And this is the summary of the DESTINY-3 trial. And boy, this is pretty mind-blowing. Kadcyla, trastuzumab emtansine, had been the preferred drug for folks who had trastuzumab and chemo refractory metastatic breast cancer. And this is what happened when we compare trastuzumab emtansine to trastuzumab deruxtecan, a dramatic improvement in progression-free survival with this molecule. But with the leakiness comes problems. And the 2 problems of note are not only the risk of cardiac dysfunction, but we add pneumonitis to the list, which can be serious in about 10 to 15% of patients and life-threatening in up to 4 to 5% of patients. And we're just sort of as cardio oncology was in its infancy, maybe 10, 15 years ago, I think oncopulmonology is sort of now the next wave of how are we going to understand what's causing this toxicity and address it. Well, this is really the last major advance that I want to highlight today. Is we talked about for immune therapy, well, triple negative breast cancer makes up only about 10 to 15% of all metastatic breast cancer. And it's in fact the minority of triple negative breast cancers that have high PD-L1 expression. And HER2 positive breast cancer is another relatively small subset of breast cancer. Well, what about the other 65, 70% of breast cancer? Well, it turns out that a very large percentage of all breast cancer does have some HER2 on it. It's just very low. What we had previously considered HER2 negative, we are now changing our nomenclature and recognizing that we should be calling it HER2 low. Because this DESTINY-04 mind-blowing trial was a study that in people we previously considered HER2 negative, who by immunohistochemistry had 1 to 2 plus staining intensity, after they were refractory to standard therapies, were randomized to trastuzumab deruxtecan versus whatever the physician thought was the best thing to do at that time, physician's choice. And again, whether you looked at whether the patient was estrogen receptor positive or all patients, whether you looked at progression-free survival, these top 2 curves, or overall survival, even from back of room or on a Zoom meeting with a 12-inch monitor, you can tell there are dramatic improvements in progression-free survival, in overall survival. And really, this was at all the ASCO meetings, this was actually the second standing ovation that I saw when this was presented this year. And within, I think, 2 months, it had been FDA approved. But cardiac toxicity, we've highlighted the 10-15% risk of pneumonitis. There still is cardiac toxicity with this molecule. LV dysfunction was reported in close to 5% of the patients. Thankfully, in most, it was grade 1 or 2. If you were looking just purely at reports of LV dysfunction by echo, of course, the numbers were significantly higher. 11.9% had grade 2 events, a 10 to 19% decrease from baseline. As Dr. Oligino had mentioned, maybe we shouldn't be paying attention to that. Maybe that is not a big deal. Grade 3 events, fortunately, were relatively rare. So the theme with immune therapy and antibody-drug conjugates, I think, is that there is just a tremendous potential for greater collaboration. Dr. Fajadi has been instrumental in leading this charge at our institution of how can we help medical oncologists to recognize early who needs to see cardio oncology. How can we get oncologists familiar with ordering this BNP and the troponins, and what do we do with all that? And so we're really looking forward to more collaboration over time so we can deliver the safest, best care for our patients. As one of the assistant directors for our clinical trials office, I can't close without a pitch for our clinical trials. We got a lot of antibody-drug conjugates working its way through our clinical trials pipeline. And with that, I will close. Again, keep in mind that this is what it's all about, is just delivering the safest, most effective care for all whom we care for. And thanks for your attention.
Thank you so much for your presentation. Just one quick question. This new therapy sounds fascinating, but it also can be used for patients who failed the Herceptin treatment, right?
Exactly. So the two studies I showed with the Kadcyla trastuzumab emtansine and the Enhertu trastuzumab deruxtecan were all in populations refractory to trastuzumab and chemotherapy. It makes it all the more remarkable.
Fascinating. Thank you. In consideration of everyone's time, we'll try to wrap up the conference. We have 2 questions, one from Anna Clover and the other one from Dr. Kuriga McPherson.
Thank you, everyone. I've really been enjoying this meeting. Just to say, I run the cardiac MR program at Stanford Hospital, and I work with David and Mina, and it's really an honor to meet all of you from the other hospitals. Just as I was listening, and I know that Dr. Baldassarre is probably going to agree with this, and she spoke about it on her section, but I think really excited by the collaboration that we can provide for the clinical care of the patients. And I get to see some of the most interesting cases when they come for the cardiac MR, and we've been building up our program for this. But I really think that in terms of where we can really bring value is obviously the myocarditis for the immune checkpoint inhibitors, which can occur so early. The other is, for AL amyloid, if we really have a suspicion in our patients with multiple myeloma, and that might save them actually an invasive biopsy, if we have a lot of the supporting imaging from the cardiac MR. And thirdly, just listening to Dr. Hall actually talk about, all of the imaging and testing we do of patients, by our guidelines and follow-up. I think that actually advanced imaging in cardiac MR has the possibility to, over time, maybe reduce the testing burden of these patients, because if we're truly able to confirm that they have, normal function, normal volumes, and they're clinically doing well, perhaps this is an opportunity to lengthen out, their imaging follow-ups, and just do more clinical assessment. So I think, perhaps this is something that in the future we can even study, and compare with some of our more stable, lower risk patients, These were kind of my thoughts as I was listening to all of you.
Yeah, really well said. Thank you.
Yeah, I completely agree, of course, with what you said. And I think I would just add to that, in the cardiac MR field, we really need to continue to work towards more efficient, faster scans. And I think as we do that, we're able to achieve the kind of 20 to 30 minute or less scan that's fully comprehensive of not just like structure and function, but tissue characterization and really get it down pat. Then we're going to be able to have more access, for patients, and be able to integrate more into regular practice, because I think that's the main, as many know, that's kind of the main hurdle at this point. The field's definitely going in that direction in MRI regardless, but I think specifically in cardio oncology, this is something that we really need to do.
Thank you.
David? Just wanted to put on my ACC chapter president's hat for a moment and thank you and Irma for putting together what was really a wonderful symposium. I'm dismayed that all of my fellows didn't tune in for the entire thing, so I'm going to make them watch. I'm glad we taped this because this was a wonderful seminar on things about which most cardiologists know nothing and should know more. This is an important burgeoning area, and just listening to all the devious ways that oncologists are figuring out how to kill cancer cells, but still hurt the heart once in a while. We need to be doing a better job. My leitmotif in my 3 years of running the ACC chapter has been to try to break apart the silos that we're all forced to work in, since we're all part of different healthcare systems and frequently competing with each other for patients. The fact that we can have an evening where we all get together, even on Zoom, where it's easiest to do, and share information and experience and knowledge, and just meet each other, I think is just absolutely wonderful and exactly what I've been hoping to do, and hopefully we'll do more of as time goes by. And I think this is a field which needs collaboration, as Neil so nicely summarized. So it's an obvious place for where we can share ideas. So I want to thank Lauren for her keynote lecture, which really set the table nicely, and for all of you for presenting the information that you did. It was just a great evening, and I didn't even miss the fact I haven't had supper yet. The other, putting on my electrophysiologist hat, I just wanted to address a few issues that Joseph raised, because I couldn't let this go. Given the way that these particular compounds interact with 3A4 and P-glycoprotein, most drugs that inhibit one inhibit the other. The other admonition is these patients shouldn't drink any grapefruit juice, which is the other common agent that interacts with that set of compounds and can screw up the metabolism of 3A4 modulated drugs. Second, if you really do have a patient with AFib you want to treat, the one drug that lends itself well would be sotalol, which is not at all excreted by any of those mechanisms, and gives you some beta blockade as well. So that would be something to think of instead of amiodarone and dronedarone, which are pretty toxic. Third, this is a good opportunity for people to who are going to go through this therapy experience to buy the Cardia app for their cell phone and record their electrocardiogram as often as you think it should be, so they don't have to wait for clinic visits to know that they're going into atrial fibrillation. It's $89 right now. I have no stock in the company, but this is how most of us are monitoring patients, and it's much easier than an event recorder, which costs money, requires insurance, and doesn't allow the patient to do it whenever they want. And finally, the question I had for using DOACs in this particular patient population, because they're all affected by 3A4 metabolism, is whether this might be a group in whom anti-factor 10A levels might be monitored to make sure that the dose of DOAC you're using is achieving some sort of therapeutic endpoint, but not to a harmful level. Is there any experience among the group doing that? I hear crickets.
Well, I didn't give this talk, but so no, and we don't typically monitor factor 10 levels directly. The issue, as he pointed out, is that ibrutinib in particular increases bleeding risk. So the recommendation is to cut, no matter what their 2 out of 3 thing is. You do Eliquis 2.5, Pradaxa you avoid. Eliquis is what you should do. The issue is if you need rhythm control, because then you're at 2.5, but they technically they're 5. So you can then increase it either right before the cardioversion, continue it 30 days after, or do 3 weeks before and do it. That's the savviness that you have to do. And you're right. If you look at there is actually a guideline statement of a deals just with ibrutinib, and it talks about antiarrhythmics, and it says sotalol is the one of choice. No Pradaxa, no digoxin, ideally no amio, and then Eliquis is the DOAC of choice.
So Dr. McPherson, we didn't use the sotalol because of concerns of polymorphic VT. Even though ibrutinib doesn't prolong the QTC, we were theoretically concerned about the possibility of VT.
Yeah, that makes perfect sense. And I'm not advocating for rhythm control therapy in these patients, at least during the time they're getting chemotherapy or immunotherapy. It's just that the pendulum is swinging back in electrophysiology to put people back in sinus rhythm more and more instead of less and less. So if one felt that rhythm therapy control was necessary, that might be something to consider. Obviously, it's a big crapshoot, and I think, as Sarah pointed out so eloquently, we're dealing with competing comorbidities and objectives, and having shared decision making with the patient to help guide your guidance of them is really crucial in this patient population. So I thought that was an excellent lecture to add to our experience here this evening. Thank you all very much for a great seminar.
Thank you so
Thank
much.
you.
Thank you. Have a great night.
Bye. Good night.
Audience. We had a good attendance today, actually. We have, at the peak, we had almost a 40 attendance.
Yeah, this was great. And thank you, everybody. Thank you again, David and Irma, for setting it up and coordinating, and for all the speakers that took time out of their evening to join us. It's great. And hopefully we can do this on a regular basis moving forward, maybe one day even in person, or at least a hybrid event.
Great.
Everybody have a good night.
Good night.
Bye-bye.
Yeah, bye.